Welcome to the Deep Dive. Today we're tackling a trio of really vital organs: the gallbladder, the pancreas, and the bile ducts.
That whole interconnected system, yeah.
Exactly. We've got some great material lined up. We're drawing from a medical textbook chapter and also an audio recording of a medical lecture.
Good sources should give us a solid picture.
Right. And our goal in this deep dive is really to give you a clear understanding of the common issues that pop up with the gallbladder and pancreas. You know, what causes them, the symptoms, treatments.
And crucially, how they all link together anatomically. It's key.
Definitely. Okay, let's start unpacking this system. Where should we begin? Maybe the basic plumbing.
Sounds good. It's actually quite remarkable how they function as a unit. The textbook lays it out well. So the liver makes bile, right?
Right, step one.
Then that bile travels down through the hepatic duct. And there's a sort of fork in the road, the cystic duct.
Which leads to the gallbladder, the storage tank.
Precisely. It holds the bile. Then when your body needs it, maybe after a meal, the gallbladder squeezes, contracts,
Sends bile back out the cystic duct, which then joins the hepatic duct to form the common bile duct.
Okay, so common bile duct is the main highway out.
Exactly. And then that duct joins up with the pancreatic duct.
Bringing in stuff from the pancreas, too.
Right. And they both empty into the small intestine together at a spot called the ampulla of Vater.
And there's a gatekeeper there?
Yeah, the sphincter of Oddi. It controls the flow. Very precise.
It really is like this intricate on-demand delivery system. And the pancreas, you mentioned it, has its own role. Well, roles, actually. Dual functions, isn't it?
Absolutely. The textbook points this out clearly. You've got the endocrine side making vital hormones like insulin, glucagon.
Blood sugar regulation, that kind of thing.
Exactly. Insulin, glucagon, somatostatin. Essential stuff.
Yeah.
But then there's the exocrine side.
The digestive workhorse.
That's it. Pumping out digestive enzymes, lipase for fats, amylase for carbs.
Trypsin and chymotrypsin for proteins.
Yep. And bicarbonate, too, to neutralize stomach acid. So it's digestion and metabolic control. That exocrine function, the lecture really hammered home how critical those enzymes are, didn't it?
It really did. If you don't have enough, it causes real problems with absorbing nutrients, malnutrition.
So people need replacements.
Yeah, the lecturer talked about pancreatic enzyme replacement therapy. Patients have to be really mindful taking synthetic enzymes with every single meal.
Wow, that really shows how vital they are day to day.
No question.
Okay, so anatomy, check. Core functions, check. Let's get into the problems. Gallbladder first. The textbook says gallstones are king here. Cholelithiasis.
By far the most common issue. And gallbladder inflammation, cholecystitis, is right up there too, especially in the U.S.
What actually causes the stones to form? Is it just bad luck?
Well, the textbook mentions biliary sludge as a starting point. Think of it like thick, concentrated bile.
Sludge, right.
And if the gallbladder isn't emptying properly, that's biliary stasis. That sludge can sit around and solidify.
Ah, so flow is important.
Yeah.
Makes sense. Diet and lifestyle must play a role there.
Likely, yeah. Though the text focuses on the mechanism. And there are different types of stones, too.
Right, not all the same.
Most common are cholesterol stones. Basically, too much cholesterol in the bile, it precipitates out.
Like sugar falling out of solution.
Kind of, yeah. Then you have black pigment stones, smaller, harder, often linked to things like chronic hemolysis, red blood cells breaking down.
Or alcohol-related liver issues.
Exactly, or even just aging. And finally, brown pigment stones. These tend to form more often in the bile ducts themselves.
And they cause blockages.
Often, yeah, leading to obstruction and inflammation right there in the duct.
So when these stones cause trouble, that's biliary colic.
That's the term, yeah. The textbook describes it as the spasming pain. The gallbladder is irritated, usually by a stone trying to pass.
How does it feel?
Intense, steady, severe pain. Can last half an hour, maybe hours.
And the location? Upper right abdomen?
Typically, yeah, RUQ. But it can also be felt in the right flank or even the mid-chest. Nausea and vomiting often come with it.
And the lecture mentioned fatty foods as a common trigger.
Definitely. A rich meal can set it off.
There's also that specific sign. Murphy's sign.
Yes. Sharp pain in the upper right quadrant when the doctor presses there while you take a deep breath in. The image showed that really well.
Pain can radiate too, right? Up to the shoulder.
Classic radiation pattern, yeah. To the right shoulder.
And here's a curveball from the text. You can get biliary colic without stones.
That's right. It seems related to issues with the biliary tract dilating or spasming, even without an obvious stone causing it. Important point.
So if that irritation, that colic, keeps happening or gets worse,
yeah,
It can become cholecystitis, inflammation.
Exactly. That's the next step, potentially. Inflammation of the gallbladder wall itself, acute or chronic.
And it's usually caused by stones.
About 90% of the time, yes, that's calculus cholecystitis. A stone gets stuck, usually in the cystic duct, blocking outflow.
What happens then?
The gallbladder gets distended, pressure builds up, blood flow can get compromised. Leads to mucosal ischemia, maybe even necrosis. Nerve irritation causes that intense pain.
But there's also the kind without stones, a calculus.
Right, a calculus cholecystitis, much less common, thankfully, tends to happen in people who are already very sick, critical illness, major surgery, burns, sepsis.
Other conditions too, sickle cell, AIDS.
Yes, salmonella infections, prolonged fasting, TPN. It's a different mechanism, not fully understood, but related to bile stasis and ischemia in those critical settings.
And the pain. It can feel like a heart attack sometimes.
It can mimic cardiac chest pain, absolutely, which makes getting the right diagnosis crucial.
The textbook had a pretty long list of risk factors for cholecystitis in general. Box 32 to 1, I think.
It did. Quite a few things increase the risk. Age over 40 is one.
High calorie, high cholesterol diets.
Estrogen influence, so it's more common in females, especially those with multiple pregnancies.
Genetics, obesity, oral contraceptive.
Well listed, yeah. Also rapid weight loss, like after bariatric surgery, certain cholesterol drugs, fibrates.
Some diabetes meds too.
Yeah.
GLP-1 agonists.
Yes. And drugs like octreotide, ceftriaxone. Pregnancy itself is a risk factor. And some anemias, like thalassemia, it's quite a mix.
And things can get worse if it gets infected. Empyema.
Yes, that's infected acute cholecystitis. Pus builds up inside. The textbook mentions E. coli, strep, salmonella as common culprits. That's much more serious. Higher risk of gangrene, perforation.
A real emergency.
Definitely.
What about the chronic side? Chronic cholecystitis and choledocholithesis.
Right. Chronic cholecystitis is more from repeated attacks or ongoing irritation. The gallbladder wall gets thickened, scarred, rigid. It just doesn't work well anymore.
Symptoms are different then.
Can be more like intense heartburn, lots of burping, gas, indigestion. Less dramatic than an acute colic maybe, but persistent.
And choledocholithesis, that's stones in the common bile duct.
Exactly. Stones that have moved out of the gallbladder or maybe formed in the duct and are now blocking that main pathway.
And that's what leads to the really obvious signs sometimes.
Yes. If the common bile duct is blocked, bile can't get into the intestine. It backs up.
Into the liver.
Right. And then bilirubin and bile salts spill into the bloodstream. That causes jaundice, the yellow skin and eyes, and pruritus.
Pruritus, the itching. The lecture really stressed that symptom.
It's a big clue for bile duct obstruction. That buildup of bile salts under the skin is intensely itchy.
Okay, so how do doctors figure out it's cholecystitis?
Starts with the clinical picture, of course. RUQ pain, maybe fever, nausea, Murphy's sign.
And labs.
Blood tests are key. Looking for high white blood cell count, markers of inflammation like ESR and CRP, liver enzymes and bilirubin levels are important too, especially if a duct blockage is suspected.
Imaging.
Ultrasound is usually the first step. It's good at seeing gallstones and gallbladder wall thickening.
What about that HID scan?
HID scan checks gallbladder function. They inject a tracer, see if it gets taken up and then squeezed out by the gallbladder. If not, suggests a blockage or dysfunction. The image showed how that works.
And ERCP. That looked more invasive in the picture.
It is. Endoscopic retrograde cholangiopancreatography. They pass a scope down your throat into the duodenum and inject dye into the bile and pancreatic ducts.
To see blockages.
Exactly. But it's not just diagnostic. They can actually do things during ERCP, like remove stones from the common bile duct or place stents. So it's therapeutic too.
Right. And the main treatment for symptomatic stones or cholecystitis is surgery.
Generally, yes. Laparoscopic cholecystectomy keyhole surgery to remove the gallbladder is the standard of care.
Less invasive, quicker recovery?
Much. Low risk, usually less than 24 hours in the hospital, according to the text.
What if someone can't have surgery?
For those patients, there are options. Medications like ursodiol or canodiol can sometimes dissolve cholesterol gallstones over time.
Takes a while, though.
Yeah, months or years, and stones can come back. And for the itching, cholestyramine can help bind those bile salts in the gut.
And diet. Need to watch fats after surgery.
Definitely need to manage diet, especially during an acute attack NPO, maybe an NG tube. Afterwards, limiting fat is often recommended, as the lecturer noted. Without the gallbladder concentrating bile, the constant drip from the liver might not handle large fatty meals as well.
Might need vitamin supplements, too. Fat-soluble ones.
Potentially, yes.
The-
ADEK, worth keeping an eye on.
Okay. Before we move to the pancreas, the textbook briefly mentioned gallbladder cancer. Cholangiocarcinoma. Sounds rare but serious.
Very much so. Relatively rare, usually affects older adults over 65.
There was a sign mentioned, Courvoisier sign.
Right, a palpable, non-tender mass in the RUQ. It suggests the blockage is likely due to something other than a gallstone, like a tumor.
But symptoms often show up late.
Unfortunately, yes. Jaundice, anorexia, nausea, weight loss, these are often signs that disease is quite advanced. Virchow's node, an enlarged lymph node above the left collarbone, is another late sign, often indicating metastasis.
Diagnosis is usually via ultrasound or CT.
Yes, but often by the time it's found, it's too advanced for curative surgery.
Prognosis is poor then.
Extremely poor, sadly. The text and lecture both highlighted that survival rates are very low.
A sobering thought. Okay, let's pivot to the pancreas now. We talked about enzyme deficiency.
Yeah.
What about inflammation? Acute pancreatitis.
Right. Acute pancreatitis, it's inflammation of the pancreas, and the textbook says it can range from pretty mild, thankfully reversible, to a really severe, life-threatening condition.
What's the core problem? What actually happens?
The underlying issue is that the pancreas's own digestive enzymes get activated prematurely while they're still inside the gland.
So it starts digesting itself.
Essentially, yes, autodigestion. That causes inflammation and tissue damage.
And what triggers this premature activation? The textbook mentioned two big ones.
Gallstones and alcohol. Those are the most common culprits by far.
How does a gallstone do it?
If a stone passes out of the gallbladder and gets stuck down low in the common bile duct, it can block the pancreatic duct where they join together. Backs things up into the pancreas.
And alcohol.
Alcohol use disorder is a major cause. Ethanol seems to cause enzymes to build up inside the pancreatic cells and triggers their early activation and release.
Are there other causes too?
Yeah, quite a few. Certain drugs can trigger it, some infections, very high triglyceride levels in the blood, trauma. Even procedures like ERCP can sometimes cause it.
And there are different types. Interstitial, hemorrhagic.
Yes, the textbook mentions acute interstitial pancreatitis, which is mostly swelling, and then more severe forms like acute hemorrhagic or necrotizing pancreatitis, where there's bleeding or tissue death within the pancreas.
How does it present? What are the symptoms?
The main symptom is severe abdominal pain, usually in the epigastric area, upper middle abdomen, often described as dull, steady, and severe.
Does it radiate?
Frequently radiates straight through to the back. It can come on suddenly or build up gradually. Nausea and vomiting are very common. Diarrhea sometimes.
Other signs.
Anorexia, fever, fast heart rate, maybe low blood pressure. If it's severe, they might be short of breath. The abdomen is usually tender, maybe distended, and bowel sounds can be diminished or absent.
And those specific signs of bleeding, Gray Turner and Cullen.
Right, those are signs of retroperitoneal hemorrhage, bleeding behind the abdominal lining. Gray Turner sign is bruising on the flanks.
Like on the sides. The image showed that.
Exactly. And Cullen sign is bruising around the umbilicus, the belly button. Those indicate a more severe hemorrhagic pancreatitis.
How is it diagnosed?
Well, clinical presentation is key. Then labs definitely checking serum amylase and lipase levels. They're typically very elevated in acute pancreatitis, as the lecturer emphasized.
That's at labs too?
Yes, checking white blood cell count, blood sugar, kidney function, BUN, calcium levels, LDH. CRP is also a useful inflammatory marker.
And imaging.
Ultrasound might be done initially, mainly to look for gallstones. CT scan is often more definitive for assessing the pancreas itself and looking for complications like necrosis or fluid collections. MRCP is another option.
Are there ways to grade how bad it is?
Yes, there are several scoring systems clinicians use based on clinical findings and lab results to predict the severity and prognosis.
What's the treatment? Is there a specific cure?
Unfortunately, there's no single cure that stops the process. Treatment is mainly supportive, as the textbook explains.
Meaning?
Aggressive intravenous fluid resuscitation is critical early on. Pain control is vital, usually strong pain meds like hydromorphone.
What about eating?
That's a big focus now. Used to be strict NPO, but now the thinking is early nutrition is better if possible. Maybe a low-fat, soft diet if tolerated.
And if not?
If they can't tolerate oral intake, then nasoenteral tube feeding started within 24-72 hours are preferred over intravenous nutrition, parenteral. Early gut feeding seems to reduce complications. Parenteral nutrition is reserved if there's an ileus or obstruction lasting more than a few days.
Antibiotics.
Not routinely used for uncomplicated pancreatitis. They're reserved for suspected or confirmed infection, like infected necrosis.
And managing electrolytes, maybe surgery if needed.
Yes, close monitoring and replacement of electrolytes. Surgery might be needed if there's suspected perforation or extensive infected necrosis. And of course, addressing the underlying cause, like removing gallstones or counseling for alcohol use.
What are the main complications to watch out for?
Infected pancreatic necrosis is a big one. Often happens after the patient initially seems to improve, then gets worse with fever, high white count. Needs urgent CT scan.
What about pseudocysts?
Pancreatic pseudocysts, yeah. They're collections of fluid rich in pancreatic enzymes that can form weeks after an attack. Ultrasound or CT diagnoses them.
Do they always need treatment?
Small ones might resolve on their own, but if they're large, like over 6 centimeters, or persist for more than 6 weeks, or cause symptoms, they usually need to be drained to prevent rupture or infection.
And systemic problems.
Absolutely. Severe pancreatitis can cause shock, hypotension, kidney failure due to low fluid volume, and respiratory failure, sometimes progressing to ARDS, acute respiratory distress syndrome. It can affect the whole body.
Okay, that's acute. What about chronic pancreatitis? That sounds like a long-term battle.
It is. Chronic pancreatitis is described as this progressive inflammatory disease where the pancreas basically gets scarred and fibrotic over time.
Leading to permanent damage.
Exactly. Loss of function. And the most common cause, again, according to the text and lecture, is long-term alcohol abuse.
Does it usually follow acute episodes?
Often, yes. Repeated attacks of acute pancreatitis can eventually lead to chronic changes, but sometimes it develops more insidiously.
And because of the damage, they need supplements.
Yes, eventually both exocrine and endocrine functions fail, so they need to take those digestive enzyme replacements we talked about earlier.
With every meal.
Right. And often they develop diabetes and need insulin because the insulin-producing cells get destroyed too.
What are the symptoms like for chronic?
The main feature is often persistent or recurrent upper abdominal pain. It can be quite disabling, often worse after eating or drinking alcohol.
Nausea, weight loss too.
Yes, nausea, vomiting, diarrhea are common. Weight loss happens because of pain, poor intake, and malabsorption. And steatorrhea, those bulky, fatty, foul-smelling stools, is a hallmark of fat malabsorption. Malnutrition is a big concern.
How is chronic pancreatitis diagnosed? Are amylase and lipase useful?
They might be elevated during flare-ups, but in late-stage chronic pancreatitis, when the pancreas is really burned out, amylase and lipase levels can actually be normal or low.
So imaging is more important.
Yes. CT scan is often the first-line imaging test. It can show calcifications in the pancreas, ductal dilation, atrophy. ERCP is considered the most accurate for visualizing the duct system, but it's more invasive.
And treatment. Still supportive.
Largely, yes. Managing the chronic pain is a huge challenge. Hospitalization might be needed for severe pain, IV fluids, nutritional support, sometimes NG tube feedings long-term.
And the enzymes in diet.
Absolutely crucial. Synthetic pancreatic enzymes must be taken with every meal and snack. A low-fat diet, small frequent meals, and plenty of fluids are recommended.
And stopping alcohol and smoking.
Non-negotiable. Those are critical lifestyle changes.
Are there surgical options?
Sometimes surgery is done maybe to drain blocked ducts or resect part of the pancreas, like the Whipple procedure, though that's more common for cancer. It's complex surgery.
And the big complication is diabetes.
Yes, that's a major long-term consequence due to the destruction of the beta cells. Insulin therapy becomes necessary for many.
Okay, lastly, pancreatic cancer. The textbook called it one of the most lethal cancers.
It has a very grim reputation, unfortunately, often diagnosed late when it's already spread.
What increases the risk?
Smoking is a big one. Excessive alcohol use, obesity, having diabetes, chronic pancreatitis itself, those all increase risk. Diet might play a role. Too high intake of nitrites, like in processed meats.
What actually is the cancer usually? Where does it start?
Most are adenocarcinomas arising from the exocrine duct cells. They tend to invade locally into surrounding tissues.
And they can block things,
Yeah.
like the bile duct.
Yes, especially if the tumor is in the head of the pancreas, which is common. It can compress or invade the common bile duct, causing obstruction. The image showed that clearly.
Leading to jaundice.
Right. And often it's painless jaundice, which the lecturer highlighted as a key, sometimes early sign if the tumor is in the head. Lymphatic spread happens early too.
What are the other symptoms? Pain?
Vague back pain can be an early symptom. Later, more constant, severe epigastric pain that radiates to the back, often worse when lying down.
Nausea, Weight loss.
Yes, nausea, vomiting, profound anorexia, significant weight loss are common. That Courvoisier sign, the palpable gallbladder, can reappear here too.
Dark urine, pale stools.
Tea-colored urine and steatorrhea from the bile duct obstruction. Pruritus, the itching, can also occur. And sometimes depression is noted even before the diagnosis.
Diagnosis sounds tough. Maybe hard to distinguish from chronic pancreatitis sometimes.
It can be challenging, yes. CT scan is usually the standard initial imaging test. Biopsy is needed for confirmation. ERCP can be very useful for visualizing bucks and getting tissue samples. PT scans help with staging.
Staging like 1 to 5.
Yes, determining how far the cancer has spread.
And treatment depends on the stage.
Absolutely. But unfortunately, many patients are diagnosed at an advanced stage where curative surgery isn't possible.
So what are the options then?
Sometimes laparotomy is done just to assess spread. Palliative bypass surgery might be performed to relieve the bile duct or stomach obstruction.
What about the Whipple procedure?
The Whipple procedure, removing the head of the pancreas, duodenum, gallbladder, part of the bile duct, is a major surgery. But it's potentially curative if the cancer is confined to the head of the pancreas. The images showed the before and after of that resection.
And chemotherapy.
Chemotherapy is often used either after surgery or as the main treatment if surgery isn't an option, or for metastatic disease. But pancreatic cancer is notoriously resistant.
So the overall outlook remains poor, as the lecture statistics suggested.
Yes, the prognosis is generally poor, making it a really difficult diagnosis for patients and families.
Wow. Okay, so wrapping this up, it's incredibly clear how tightly linked the gallbladder, pancreas, and bile ducts really are.
Absolutely. Dysfunction in one part really does ripple through the whole system, affecting digestion, nutrient absorption, metabolism, just overall health.
And understanding just the basics of the anatomy, how the plumbing fits together, really helps make sense of why, say, a gallstone can cause pancreatitis or why a pancreatic tumor causes jaundice.
Definitely. It unlocks the why behind the symptoms.
We've covered a huge range today, from something super common like gallstones, which many people experience, all the way to the devastating diagnosis of pancreatic cancer.
A really broad spectrum of conditions affecting this small anatomical neighborhood.
So maybe a final thought for everyone listening. Given that some of these serious conditions, especially pancreatic issues, can have pretty subtle signs early on.
That vague back pain, maybe some indigestion.
Right. It makes you think. What proactive steps can you consider, regarding diet, lifestyle? Things we can control. And maybe more importantly, when should persistent abdominal symptoms, even if they seem minor, prompt a conversation with your doctor?
That's the crucial takeaway, isn't it? Being informed is great, but being attentive to your own body and seeking timely advice when something feels persistently wrong, that's invaluable.